Thank you. All right, welcome everyone to tonight's presentation, Pain 101, how to manage different types of pain and how to best manage it. And our presenter tonight is Andy Donald, geriatric pharmacist, and we'll introduce Andy in a minute. But first, just some housekeeping notes. You'll notice that you see us, but we do not see you on this webinar platform, and you are all muted. So your cameras are off and you're muted. Andy will take questions at the end of the presentation. So in order to ask the questions, if you can enter them in the Q&A tab. So if you move your mouse or touch your screen, there will be a little, two little bubbles that say Q&A. And if you click on there, you can type your questions in there for Andy and we will read them out to him at the end of the presentation. All right, so it's my pleasure to introduce Andy, and we're happy to have Andy back. He's presented for us before, but it's been a little while, so welcome back. So Andy is a certified geriatric pharmacist and the president of the Health Depot Pharmacy. His passion to help patients and deliver personalized services led him to launch the Health Depot, Canada's only online clinical pharmacy. So patient care is Andy's #1 priority. He and his pharmacy team are specialists in supporting older adults with chronic conditions such as diabetes and cardiovascular disease and those living with dementia. Andy is very active in his profession, serving on several committees, including the Alzheimer's Society of Ontario's Ontario Dementia Care Alliance, and he is the Prescribe It Pharmacy Ambassador for Canada Health Infoway. So welcome, Andy, and I'm going to turn it over to you.
Thank you very much. I'm just going to go ahead and try to share my screen here. Let's see if it works for everyone. Can everyone see my screen? Whoops. Can everyone see that?
Yeah.
Okay, perfect. Okay. Sounds good. So yeah, as we mentioned, today's topic is Pain 101, different types of pain and how best to manage it. I am Andy Donald, a certified geriatric pharmacist, which just means I can help personalize medications for you based on your body. We call them clinical pharmacists, and we're a clinical pharmacy here in London, Ontario, actually. And before I jump into it, I just want to read everyone a disclaimer that the content of this webinar is for informational purposes only. It's not intended to substitute for professional medical advice. Always seek your doctor and your clinical pharmacy and your pharmacist team, everyone in your circle of care before making any kind of changes to your medications. There's always some reasons why you might be on one medication or another. This is just general knowledge and educational purposes. If you wish to learn more about this presentation or have any other questions about your medications, please reach out to the Health Depot. We're more than happy to help. So without further ado, let's get into the presentation on Pain 101. I always like to start these presentations at the basics and build towards more complex at the end. And definitely, please feel free, any kind of burning questions, to throw them in the chat there and we'll answer them all at the end. There'll be lots of time for questions at the end. So first of all, what is pain? Pain is an unpleasant sensory or emotional experience, and it warns us that something is wrong or damaged in our body. It serves a purpose. It tries to get us to stop causing more damage and making it worse. So there's two different classifications of pain: acute pain or chronic pain, right? Acute pain is an injury to our body that lasts only a few minutes to maybe a month or so. It warns us of actual damage that has occurred, and the pain generally goes away when it heals. Examples of this are burns, cuts, broken bones. Chronic pain, on the other hand, persists for over 3 months and occurs long after the injury has healed in the absence of any new trauma. Examples of chronic pain are arthritis, nerve pain, and lower back pain. Now, there's two main types of pain. Types of pain determine how you kind of treat it. And so the main two types are nociceptive pain or neuropathic pain. Nociceptive pain is the most type of pain that most, I'd say 90–95% of people experience. It's muscle, joint, bone, organ pain. Gives a sharp, achy or throbbing sensation. Examples of this are muscle strains and sprains, joint pain, and broken bones. Whereas neuropathic pain is damaged nerves that cause them to misfire and send signals. It gives a burning or shooting sensation. Some people call it like lightning bolts, or a tingling sensation in your fingers. Examples of this are fibromyalgia, shingles, and diabetic neuropathy. Yes, fibromyalgia is not in people's heads. It's been disproven a long, long time ago. It's micro tears or cuts in your nerves that cause them to fire often. That's what fibromyalgia usually is. This is now, let's look at the pain process. How does it happen? So if you experience like a burn on your finger, it travels from smaller nerves to bigger nerves, all the way up your arm, into your spine, in your back, and into your brain where you sense and feel the pain. Well, in your brain, it's modulated in the center of your brain. Our body then feels the pain and releases its own painkillers, endorphins and enkephalins, and yes, opioid peptides. Our body makes its own opioid peptides to block out the pain. So what happens with age that can make pain, unfortunately, a little bit worse? Well, there's two main things that happen as we age. We get the first one being we get an increased pain threshold. So instead of you feeling pain at a lower level, it's now we're not sensitive enough, to sense pain until it's a little bit higher. As a result, that's because we have less nerve, pain receptors, and pain signaling molecules in our body. This means that we notice pain late after more damage has already occurred, which can mean that the damage can get a little more severe. And then once we do feel that pain, we have less pain inhibition, as we have less of those endorphins, the enkephalins, and endogenous opioids to block out the pain. So we get a lot of sources of pain throughout our lives. And as we tend to get older, there's a chance for more and more of those pain injuries to stack up and cause, whether it's from fractures, ulcers, neuropathic pain, cancer, fibromyalgia, lots of different things can accumulate over the years. The consequences of not treating your pain can be severe, as they can cause sleep disturbances, functional decline, as if you have, for instance, arthritis in your knee and you exercise less, then your muscles around your knee get weaker, so more weight and more goes on your joint, which causes even more pain, so cause you to do even less exercise, and it can be a downward cycle. It can cause depression, anxiety, anger, polypharmacy, which is taking too many different medications, 5 or more prescriptions, then cause lots of side effects. Malnutrition, decreased socialization, and distress and dementia even. So chronic pain and aging, 2/3 of older adults over the age of 65 report that they have chronic pain. 83 of those who experience the pain says that it interferes with their daily activities and their quality of life. The most common forms of pain that people experience over the age of 65 are osteoarthritis of the knee and hip at 58%, and 35% is lower back pain. It's important to know that although a lot of people experience more pain as we age, chronic pain is not a natural part of getting older. It's just an unwanted consequence of a lot of different injuries over the years stacking up and wear and tear. Treatment is needed to help treat the pain, because pain untreated can affect all aspects of your life. There's something we call a sleep pain depression cycle, unfortunately, as 50 to 80% of patients with chronic pain have a significant sleep disturbance. It's tough to fall asleep when you're in pain, if you have shooting pain or throbbing pain. Sleep disturbances then are one of the largest cardinal symptoms of depression. If you're not sleeping enough, then it's tough for also your pain sensitivity to heal wounds, and it can actually increase your pain sensitivity. There's something called the wind-up phenomenon, that when you get repetitive pain, it can sensitize our neurons in our spinal cord that then can cause smaller stimuluses to cause even bigger pain. So something that wouldn't have caused pain before now causes much more pain. The reason for that is our peripheral and central nerves remodel themselves. The synapses become stronger, and then we get exaggerated feeling of pain. Kind of like, if you think about it, that's why I have the muscular Santa Claus on the bottom right here. It's because if you think about it, if you lift some weights over time and you keep using that, and then your muscles get stronger and bigger. The same kind of thing happens with your nerves. If we fire them too often, our body adapts and makes those signals stronger, so we get even a stronger sensation of pain. So chronic pain causes sensitization if we don't treat it. So it's very important to not ignore it, or it'll come back to bite you even harder. It's important to get treatment. There's a lot of different things we can do to treat, just like all conditions. Physical therapy, exercise, psychological support, alternative medicine. Now, I often always try to focus on doing the non-pharms and the lifestyle changes first in all conditions. Sleep is one that's so much things we can do without reaching for a medication bottle. That's so much better for us, because sleep medications are the worst ones out there that really affect us in a negative way, believe it or not. Whereas for pain, unfortunately, often, we can do some things with their lifestyle, but often we do need a little bit of medication to help us to control that pain. First, we'll talk about the non-pharm, because we want to try to do those first. And then we'll talk about the medications. So often these can be done to help improve how bad the pain is, and limit how much medications we need to do. Exercise is probably the most important thing. Doesn't have to be strenuous, but 30 minutes a day for 3 to 4 times a week is very important. It can be walks, simply walks, or pool, like, swimming in the pool is very, very important. As I mentioned for you, that example of 58% of us, chronic pain is because of arthritis. Arthritis most of the time is in the hands, knees, the joints, like a lot of times weight-bearing joints, like the hip and the knees. And if we don't exercise and keep those muscles strong, strong muscles around the joint actually relieves the weight off the joint. If they become weak, the muscles, then a lot more weight goes on the joint and causes even more pain and even more functional decline. Exercise is very, very important. Physiotherapy can help you how to target and heal wounds and even make them stronger. Occupational therapy is also important. Chiropractic or acupuncture is more on relieving tension and some kind of like anesthetic sometimes with acupuncture. There's massage can help with tightening of muscles, hypnosis, heat and cold therapy. Now there's heat and cold sensation that are in topical solutions. We'll talk about that later, but actual heat source like a hot pad or ice, or something very, very cold. A lot of the recent research, we used to do a lot of cold therapy, put ice on it kind of thing, that can help reduce swelling. But ice has been found a lot more lately to reduce blood flow to the area, which means then less recovery. More blood flow means more recovery, more healing. Whereas if you use cold, then it delays healing a lot. Whereas heat can be, help with it, especially if you have tight joints and things like that, to get it going again. TENS therapy, a lot of us have heard of that, Dr. Hose. Transcutaneous electrical nerve stimulation is what it's called. It kind of works like an anesthetic, where you're overloading the pain receptors in the skin area to ignore the throbbing sensation. I'll kind of explain that a little bit more in the slides coming up, but that's kind of how it works, like another anesthetic. Now, why is pain so difficult to treat? It's because it's very subjective. It's how we feel as the individual. As we just told you, if you don't treat it, the pain sensation for the same issue becomes worse because we get more signal from it. The main point is, it's very tough for you to, if you have chronic pain, to experience no pain. The important part is we need it to be more mild pain. That you can tolerate, so it doesn't affect your quality of life and basic activities, like doesn't stop you from going out for a walk with family. We need it to be manageable and not severe. There's lots of different classes we'll talk about, generally from more mild pain to more severe down on the bottom. Topicals, more mild. Over-the-counter medications that can be used to help for treating pain. Nerve pain is more so obviously for the neuralgic pain. There's certain medications that are specific for those. Cannabinoids, cannabis, yes, we'll talk about that. I'm sure we'll have lots of questions at the end. Pretty groundbreaking, helping with moderate to severe pain, very effective. And opioids, which gets a lot of bad publicity as warranted, because they can cause a lot of side effects and a lot of issues, particularly in older adults. But they are still the most effective for very severe pains like broken bones and cancer pain, things like that. They still are necessary, but they need to be reserved as a last resort. So first, the topical anesthetics. So how these work, that's a lot of examples you've probably heard of. You can see in a pharmacy, Rub 5A35, A535, capsaicin, Voltaren, Myoflex, icy cold, hot pads. You've probably heard of those, and Tiger Balm. They all use, if you have like a sore, you pulled a muscle in your elbow and it's throbbing. The idea is you rub the anesthetic on the whole area there, and it creates a burning or a cooling sensation. Burning and cooling sensation, those are forms of pains. They also trigger your pain receptors. The idea is if you overwhelm all the pain receptors in an area, then the messaging going up to your brain is just the burning or the cooling sensation. It drowns out the throbbing pain of your elbow. Important to say, it's not a fix. It masks the pain and masks the issue that you can actually, if you ignore it and you numb it too much, then you can actually make the pain worse if you still use that muscle. The idea of pain is to stop you from causing further harm. So the only one out of these that's a little bit different, I would say, is Voltaren, because it's also an anti-inflammatory. It does have properties that is anesthetic, but it also reduces inflammation. Voltaren diclofenac is actually one of the stronger anti-inflammatories, but it's in a topical form. Now, I kind of blew it there, but I always like to ask people, I guess we don't have too much conversation going on this chat, but I always like to ask people, what is the safest medication that doctors and everyone always goes to, requests you to try first for pain? Like, just think about it. What is the safest medication for pain? A lot of you, 9 times out of 10, get this. It's Tylenol, right? Acetaminophen. It's a first-line therapy for most types of pain, especially arthritis or any of the chronic medications, the chronic conditions. The main things we need to be concerned about with this is very safe, not very little drug interactions, but is we have to watch how much we get of it from all sources. A lot of acetaminophen is inside most over-the-counter products and cold therapies have acetaminophen, sometimes 500 milligrams to 1,000 milligrams in one serving. So we have to watch to make sure we're not going over 4,000 milligrams a day. That's for the average adult, younger adults. But as we get older, we should keep that below 3,000. And if we're over 80, even below 2,800, as it can cause damage to our liver. And we also have to be aware that, we might need to consider other options if you consume a lot of alcohol. Alcohol makes the Tylenol, sometimes, it depends on how much you drink, but it can make it 9 times more toxic for your liver. It converts it into a more free radical form that can cause a lot more damage. Yes, your liver heals over time, but if we put it under too much stress, that's where you can see people can get permanent liver damage over time. It's interesting, though, that the safest medication out there is bound to, we didn't even know how it worked in our body, acetaminophen, until the end of 2017, 2018. We just knew if you took it, it helped the pain go away. But in 2017, 2018, at the tail end of 2017, they figured that it bound to cannabinoid receptor 1 in our body. Cannabinoid receptor 1. What else do you think binds to cannabinoid receptor 1? You're right, cannabis. It's very interesting. That's how it acts. Our acetaminophen binds in our brain and our peripheral system to cannabinoid receptor 1. Well, there's 2 main cannabinoid receptors. There's cannabinoid receptor 2 as well that cannabis binds to. So it works even better. We'll talk about that coming up, but that's interesting. We'll touch base on cannabis more later, but the safest medication that we always get recommended binds to the same receptor as cannabis. Now, other over-the-counter meds. Anti-inflammatories, also called non-steroidal anti-inflammatory drugs, or NSAIDs, if you hear people using the lingo for short form. That's ibuprofen, naproxen, aspirin. Those are over-the-counter ones. And then diclofenac and meloxicam are just a couple of the prescription ones. They inhibit our ability to make prostaglandins in our body. Prostaglandins are used in the inflammatory process. So what they do is they work by inhibiting pain and inflammation. Now, because of that, though, it also can cause other issues in our body. We actually use prostaglandins in our to create our nice coating in our stomach to protect it from this harsh acid in our stomach. So if you take anti-inflammatories and you're not careful with it, that can eat away at your stomach lining and to the point that it can cause an ulcer and also your upper GI tract. It can cause, we have that thin coating that protects our arteries and our heart and whatnot too. So sometimes taking too much of it can cause our arteries to be a little stickier. That can cause accumulation of plaque towards atherosclerosis and renal impairment. It can hurt, damage and hurt our liver. And in fact, it can cause our blood pressure to rise uncontrollably, where if you take blood pressure medications, if you take an anti-inflammatory every single day and you have high blood pressure, sometimes you see patients on 4 or 5 blood pressure medications that they think that they're not working, but it's because of the anti-inflammatory, because it causes us to retain water and sodium in our body more, while also potentially damaging our kidneys long term. It's for this reason why anti-inflammatories, yes, acutely, if you pulled a muscle or something like that and you got some swelling, you can take it for pain, but it's best not to take long term. It's best to only use for short durations and then reach more for the Tylenol bottle for more chronic pain. Muscle relaxants. The over-the-counter muscle relaxant, methocarbamol, is in Robaxacet. Robaxacet is acetaminophen. Robaxacol is aspirin. Robax Platinum is just ibuprofen. They're with all methocarbamol. Regular strength versus extra strength is the same amount of methocarbamol, but just a regular strength Tylenol versus an extra strength Tylenol. It's important to know that and not double up on your Robaxacet, because you're doubling up on the side effects, which can be a problem. Cyclobenzaprine is an over-the prescription muscle relaxant. It's actually kind of interesting they're called muscle relaxants because they may not actually relax your muscles at all. That's a general thought. Instead, what they do is they help reduce our pain, but also make us drowsy to help us fall asleep. They don't actually relax your muscles whatsoever. Because the main side effect of these muscle relaxants, methocarbamol and cyclobenzaprine, is drowsiness and dizziness. They can actually even drop your blood pressure a little bit. That's why we don't double up on the pills. Instead, you just take an extra Tylenol if you need to, or just take the extra strength, because the extra strength Tylenol. Don't double up on the Robaxacet because you're taking too much of the methocarbamol, which can make you way too dizzy and can even impair your driving. Now, nerve pain. I mentioned to you nerve pain, that shooting, burning, tingling sensation. It's because of damaged nerves. And a lot of the medications, a lot of them that can be used to treat nerve pain. There's the big three, though. We'll discuss those coming up. But the idea is like there are medications, like 30 or 40 main ones that can be used to help. They just notice when you take these for other conditions, they help to block the transmission of that nerve pain in our body. The duloxetine, gabapentin, and pregabalin are the big three. Duloxetine, is also known as Cymbalta, is a serotonin norepinephrine reuptake inhibitor, SNRI. Very similar to Effexor, which is venlafaxine, which is a medication helped with mood, and as well mood, depression, anxiety, lots of different things, stress. Very good medication for that. But they found that it helps with nerve pain. And for that reason, it's one of the drugs of choice for neuralgia. It's preferred to be used as a neuralgia medication even than a mood medication. It's better for that. But if you have both issues, then it can be a great one that can kind of kill two birds with one stone. Whereas anticonvulsants, gabapentin and pregabalin, pregabalin is also called Lyrica, if people recall, they also can help with nerve pain a lot as well. What's the right one for you depends on how you tolerate side effects, and they have to be very individualized for you. Carbamazepine is another good one for one specific nerve pain. It's one of the best ones for trigeminal neuralgia, which is often pain in the face that shoots across the face. But because of side effects and drug interactions, it's very limited in its use to just that. Tricyclic antidepressants, on the other hand, amitriptyline and diazepamine, have been used a lot. They were originally designed as antidepressants. They can be used for burn pain and if they're very, very severe. But because of the side effects, they're one of the worst anticholinergic drugs out there. They can cause atrocious effects and lead towards dementia long-term. They're best not used. There's a lot of other alternatives that are better for nerve pain. So now onto cannabinoids. So I'm sure we're going to get lots of questions at the end for this. Cannabis relieves pain primarily from THC is one of the portions. Tetrahydrocannabinol is used for seizures, pain, inflammation, anxiety, nausea, depression, and migraine. Okay, that's what gives cannabis and marijuana the bad name, is the THC. But in the recreational, it's ridiculously high. And in medical cannabis, it's either very, very low to help you sleep at night, or not even in the cannabis whatsoever, in the oils, okay? It doesn't necessarily need it. It can, in very low levels, be very advantageous and helpful, but it doesn't cause all the nasty side effects because it's a lot lower than the recreational. Then cannabidiol, on the other hand, is used for glaucoma, insomnia, appetite, nausea, and anxiety. It's very effective for all those. A lot more research going into the terpenes that's in cannabis that helps with pain, inflammation, nausea, anxiety, and depression. The side effects of THC is what gives everything the bad name in the past, but it's making waves now because obviously low doses are very, very beneficial. High doses affect your memory, coordination, and cause slower reaction time, absolutely, but low doses are very effective, particularly at night and helping you sleep. Cannabidiol and terpenes have much less side effects, only some very, very minor dizziness, appetite, changes to your appetite, and sometimes very, very mild diarrhea. But the main thing with cannabis, and why often I hear this all the time as a clinical pharmacist and a certified geriatric pharmacist, often patients are upset and say, why will my doctor not suggest cannabis and let me go on cannabis? It's because it's one of the worst drug interaction medications out there, unfortunately. That's just one caveat. Doctors are scared of it. Doctors don't know what to do to how it'll affect and change all your other medications. It literally inhibits most of your liver enzymes. So that means a lot of your other medications that, as we age, because our liver function goes down every year of our lives, our kidney function goes down even more, medications already stick around longer. Now, if you add cannabis in there, they'll stick around even that much longer as well. It sounds kind of scary, but all you need to do is you have to have a clinical pharmacist that works together with your doctor and consults on how to switch your medications. You just have to lower the other medications. Kind of like if you go on warfarin. A lot of times you have to adjust your warfarin and some of your other medications based on your warfarin dose. Same kind of thing with cannabis. You need to get onto a consistent dose that can help you out for pain. But then a lot of times that means your medications, blood pressure pills, everything might just have to be halved or even quartered. Sometimes you may not even need a medication anymore. If they're sticking around longer and acting longer in our body, they'll be more effective. So we just need to lower the doses. Now, there's an older adult study for medical cannabis that was done that showed how well medical cannabis is tolerated. They looked at older adults, yes, older adults that were only taking cannabis, not other medications. So it shows only 4.9% of the individuals had like a side effect, an adverse event after 3 months, and only 1% at 6 months, showing the tolerance develops to side effects over time. But a lot of times the side effects you get are because of your other medications in your body if you didn't have them adjusted. And then also they found that 3/4 of the individuals in the study reported massive improvements to their pain, 63% improvements to their sleep, and 3/4 again, drastic improvements to their quality of life. Significant reduction of prescription med use as well was found, as there was a 63% decline in the amount of people using opioids and the amount of opioids. As if you're getting more pain control from your cannabis, then you don't have to use as much of the harsher medications, opioids, that have a much more drastic effect on our quality of life and how making us feel out of it, and dizziness and all that kind of stuff. And then they also found that 55% reduction in the prescription drug costs overall. Now on to the opioids. Sorry. With opioids, all these ones are opioids. Tramadol, yes, even though it was not considered opioid until recently, it is now finally by Health Canada. That should never have happened. It's a milder opioid, still an opioid. Codeine, morphine, hydrocodone, oxycodone, hydromorphone, fentanyl, methadone are just a few of them. Codeine, believe it or not, is a prodrug of morphine. Codeine actually doesn't do any painkilling action in our body. The reason why it's banned in most hospitals is because there is 1/4 of the population that can't even use codeine properly, that don't have half of those, so 1/8 of our population don't even have the liver enzymes needed to convert codeine into morphine. So if they take codeine, they get no painkilling action whatsoever. They'll get it, codeine will definitely help them with their cough, but it won't help them with pain. Whereas there's 1/8 of the population of that 1/4, 1/8 of the population in total, convert too much codeine to morphine. So a small dose of codeine will drastically affect them, and so much of it will be converted to morphine. For that reason, it's often best that you just get on a stable dose of morphine because you know what you're going to get all the time. So how opioids work in our bodies, they block our signals traveling to our brain for 3 different receptors: mu, delta, and kappa receptors. There's no signal to this effect. But the main thing is, as you always hear of opioid overdoses, is it has to be gradually increased as our body gets used to it. You have to go very slow and then increase over time. The problem is our body gets used to it and needs higher and higher doses anyways. And it's very, very tough to get off these medications, just like sleep hypnotics, like benzodiazepines, which are atrocious. And zopicone is a benzodiazepine receptor drug too. So what happens in our body, if you think of it this way, is we have all these nerves with nerve endings that shoots a signal from one nerve to the other to keep the signal going. Well, if you have a nerve receptor and you have too much signal for opioids, what happens is if we have 10 receptors here and we have regular endogenous opioids to cause pain relief, but now if we put a whole bunch of drugs in there, opioids, we get too much signal, our body then gets rid of some of the receptors, okay? And the wires. And then we need a higher and higher dose to have the same effect. If we go on a higher dose, then our body keeps getting rid of it. Our body likes everything to be at an even keel. And it always tries to go back to the way the amount of signal it wants. So eventually, you had 10 receptors down to 1 receptor. That means now if you try to get off the medication, don't take it, your body's going to freak out because it wants 10 signal, but you're only giving it 1. As a result, to come off these medications, you have to work very, very slowly over a long period of time, sometimes 6 months, over years it can be, to slowly regrow the receptors again. And you have to have a deficit now to your body to want more of it to slowly go down in the dose, okay? So because of all this, though, with the sealant effect and all the nasty side effects, we'll show this on the next slide, the side effects, we reserve this for severe pain when all the other treatment options have been exhausted and are ineffective, okay? There's a lot of drug interactions, and the side effects are much, much worse as the older we get because they can accumulate and cause issues with a lot of other medications. So they can cause almost all the time. If you're on an opioid, you're going to have constipation. You can get dry mouth, nausea, vomiting, sedation, sweats, urinary retention. So issues going to the washroom. Those are common side effects that almost everyone gets. But then it also can cause hallucinations, bad dreams, dysphoria, seizures, itchiness, respiratory depression. It can have a big effect on your hormones. But if you do need opioids, yes, they're very important. Like if you have broken bones, severe cancer pain, things like that, you may need an opioid. At that point, you may need to manage some of your side effects. Often we don't like the side effect of one drug to be treated with another drug to be treated with another drug. We have too much of that problems out there already with polypharmacy. But in these circumstances, yes, you most likely will get constipation. So if it doesn't resolve, what happens is, think of it as musical chairs. If you have so much of a medication, this is what side effects are. Instead of sitting in one chair, if there's only one chair for it to sit in and it's already blocked, that molecule travels around our body and tries to sit in any other chair that is almost its size. So it's binding to receptors that it wasn't really intended to. So how it causes constipation is opioids will bind in your gut to receptors that causes it to stall. It kind of paralyzes your gut. So instead of it moving nice, your bowel movement, it kind of just stops. And as a result, your body absorbs too much of the water and it becomes very, very hard. Well, Senokot is the preferred medication to take if you have narcotic-induced constipation because it'll bind in your gut and get your gut moving again. Whereas bulk forming laxatives such as fibers and Metamucil actually can cause more problem than good because if your gut's not moving, it's something to clutter up your gut even more. So yeah, Senokot's not very, very effective in people who don't have narcotic-induced constipation. For regular constipation, because it can cause lazy colon, it's best not to use that unless you're taking it for narcotic-induced constipation. Then nausea and vomiting is very much common as well. You can help that by eating more frequent, smaller meals. And also there's medications that can be used to help treat nausea and vomiting. So there's so many other health conditions that can cause, like as we age, I mentioned your kidney function, liver function, kidney function go down, blood volume changes. So much in our bodies change that then the side effects and the usefulness of our medication continually change as well. So what's the best combination of medications and pain medications for us? Well, your pharmacist is someone who can help a lot. Make sure it's very important that you talk with your pharmacist and work together with your doctor so that you can have adequate pain control. So it's just mild, it's manageable. We can help personalize meds for you. And that's what clinical pharmacy is all about. And that is why I formed the Health Depot in the first place. We are a part of now Green Shield Canada. Last year I joined, we're here in London, Ontario, we're expanding right across Canada, but we joined Green Shield Canada, which a lot of you may know as a big insurance company. But a lot of you may not know is that they're a not-for-profit insurance company founded by pharmacists in the 1950s. And their slogan is where health is improved health for all. And they're really looking to donate $75 million in the next 2 years to help improve people's lives. And that's why I decided to join up with the Health Depot. And we're also the preferred pharmacy for the Alzheimer's Society of Ontario. Our slogan is where health comes first. A little bit more about this is the passion, the reason why I formed the Health Depot in the first place is because we have a big medication overuse problem in Canada. It's a worldwide problem. But in Canada, the Canadian Institute of Health Information, last time they did these stats was in 2016. They said that 2/3 of seniors over the age of 65 were on 5 or more prescriptions, a quarter were on 10 or more prescriptions, and 1 in 12 were on 15 or more medications, a whole mittful at this point. And the reason for that is because as our bodies age, as I mentioned to you, our bodies changes. Our kidney function, liver is what chops up our medications into byproducts so we can get rid of it. Our kidney function is what filters out both the unchanged drug and the metabolites of the drug. So if those are going down every year of our lives, that means meds are accumulating in our body. And the side effects often go unnoticed, and the side effect of one drug is treated with another drug is treated with another drug. This is a big reason why compliance for medications in Canada is below 50%. Less than half of Canadians take their meds as prescribed by their doctor. It's not that they're forgetting to take their meds often, it's that they're choosing not to take their medications because they don't make them feel good. And it's not just that we're on too many medications, it's that we're on the wrong ones. As a third of Canadian senior hospital visits, 1 in 3 seniors that walks through the door of the emergency room is due to them taking one potentially inappropriate medication. Potentially inappropriate medication is a medication that is unfit to be taken by anyone over the age of 65 because there's the side effects and the safety of them are horrendous. The point is that there's a much safer alternative to be used to treat the same condition. And yet 31.1% of Canadian seniors are chronically taking one of these medications, unsafe medications, every single day. There's a medication list called the Beers List medication, a list that is a 21-page document that outlays a lot of these medications and class of meds that should not be taken by older adults. This here is a picture of your kidney function over time. As I mentioned to you, kidney function decreases over time. The top line is males as we age from age 20 down to 90, as you see there, and the bottom line is females. Well, yeah, creatinine clearance on the left there, it's easy to determine. That's in your blood work. Anytime you get your blood work done, it has your creatinine clearance. That tells us what your kidney function is and helps us to know what to adjust your medications to that are safe for you to help personalize your medications. Well, interesting fact is that a lot of clinical trials in the pharmaceutical industry do the clinical trials in healthy 20 to 30 or 20, 40-year-olds, even if they're meant for an 80 to 90-year-old. So the reason why they do in young adults is that in any clinical trial, you need to control for the confounding variables. So, which means you need control that makes sure that people aren't taking other medications or have other health conditions that could throw off the results of the study. So you know exactly what the study is determining. Well, the truth of the matter is they also do it in young adults because young adults have low side effects. I even had a friend who did it to help pay for his university education to drug studies. They paid really well. Well, that's a bit of a concern because I don't know if you remember back when you were 20, 21 years old, back in university, you could go out to 3 or 4 in the morning at a bar and drink a lot of alcohol and then wake up the next day and go to work at like 6, 7 o'clock in the morning and just bounce out of bed and be okay. Try doing that in your 30s or your 40s. It ain't happening. So it's because young adults, their bodies can process things a lot easier and they can make very good side effect profiles that look great to get drugs approved and for doctors to prescribe them. Well, then there's a dilemma that happens that when we get those safety and tolerances and thresholds of young adults are then applied to an older adult who have less liver function and 3 to 4 times less kidney function. Those same doses and dosing ranges for the young adults can be hazardous and even toxic to older adults. It's important to know that dizziness is not a normal process of aging. Confusion, tiredness, and dizziness all the time suggests you're on doses that are either too high or you're on too many medications. So who's to blame for all this? People are quick to point fingers with this medication overuse problem and the wrong types of medications as doctors' fault. Well, I grew up in a big doctor's family, and I can tell you that couldn't be further from the truth. You see, doctors and pharmacists both go to school for 4 years. Doctors spend 95% of their schooling on diagnosing and healthcare procedures. The most important part of the healthcare system is knowing what's wrong with you. Okay? If you don't know what's wrong with you, we can't really fix you. And then knowing a good action plan to get you fixed and doing procedures to get you fixed. Whereas doctors only spend 5% of their education on medications. Pharmacists is the opposite. We spend 95% of our schooling on medications. Yet when we get into the community, in the real world, doctors are responsible for diagnosing you, but then they're the ones who select what medication to give you and then monitor the safety of the medication, and they're supposed to adapt your medication to you as you age that they never really learned much about in school in the first place. It is the healthcare system's fault for this. It's healthcare silo in the community that has not allowed pharmacists to help out in the past. We've been on the outside looking in for years, We haven't even known diagnosis, no information available to pharmacists to even help out in the decision tree on helping make sure it's the right medication, the right dose for you. Pharmacists need to help fix this huge Grand Canyon of a problem in our healthcare system. It's not just a crack. It's a huge problem in our healthcare system. But in order to help, we require diagnosis information, health records, and lab work. And also, a third of Ontarians don't have a family doctor. I grew up in a big doctor family. My dad's a 72-year-old physician still working full-time up in Midland, Ontario. And he refuses to retire because over 50% of the surrounding area in South Georgian Bay don't have a doctor. It's bad. It's epidemically bad in rural communities. In an ideal healthcare system, pharmacists can help. Doctors should focus on what they went to school for in the first place and diagnose all health conditions and perform healthcare procedures. That's the most important part I told you. Pharmacists then, based on the diagnosis, can help select the right medication for you based on side effects, drug interactions, and how your body processes them. A lot of time medications were only intended to be taken for a month or two, and yet you see patients taking them for 20, 30 years because no one stopped them on the medications. We also need to help to make sure, okay, you're done with this, and how to triage you and step you down off of medication, like a stomach acid drug if you don't need to take it anymore. Pharmacists never used to have access to this important information to help though, but it's exciting that we now do. With Clinical Connect and Connected Ontario, you can get access to any of your patient's health records in all of Ontario. It's the same system that all the hospitals use. If you go from London to Ottawa to visit family and you unfortunately land in the hospital, they have access to all your information, your diagnosis, your doctor's reports, your specialist reports, your medication history, your lab work, both in the community and the hospital, all get uploaded into this e-health platform. Well, we have this at the Health Depot for any of our patients in Ontario, and our clinical pharmacists, I'm one of them, can help design and figure out the right medication for you based on how you're feeling, but also based on your body, on your kidney function, your liver function. Certified geriatric pharmacists can adapt medications based on our bodies as it changes. As I mentioned, kidney function, liver function, and other medications, we can personalize them. Unfortunately, right now, this certification is only available in the United States, but I'm working together with the University of Toronto Pharmacy School to get into their curriculum. We're making a partnership with them because I see this as the future of our profession. It's very important. After all, love this last summary slide here for this passion side. You can have many different doctors. A lot of people have 5 to 6 different doctors and specialists. Unfortunately, all don't talk to each other. A lot of times because they don't know much about each other's medications at all. Dr. Hart, your cardiologist, yes, they know a lot more about after med school, like the undergrad med school portion. To become a specialist, you have to do 2 years and pass an exam knowing cardiology medications a little bit better. Just like Dr. Brain has to know neurology medications more, but they don't know each other's medications. The only one who sees it all and understands it all is your pharmacist. It's on the pharmacist going forward in your circle of care to be that triage point and be your voice and advocacy between the doctors and make sure it's the right med and the right dose for you. So Dr. Hart, we should be able to reach out to Dr. Hart and say, hey, Dr. Hart, we need to change the patient from this blood pressure pill, this blood pressure pill, because Dr. Brain put them on this pill. And also you're based on the patient's kidney function, this is probably the best medication to give. And Dr. Hart's like, oh my God, thank you so much. Yes, please do that. That's the future of what we need to do. So that's the passion why I made the Health Depot, where health comes first, why partnership with the Alzheimer's Society, why we're now technically not for profit, and we're working together with McCormick Home. And it's really exciting because we're bringing a few other things that we're doing besides just the clinical. Is we built a pharmacy around that. We bring the pharmacy to you wherever you are, with free delivery anywhere in Ontario and expanding right across Canada. We have a new facility out in Winnipeg. We're opening one in Burnaby as we speak, and we're going to be on the East Coast next year. We're right here in London, so we have same-day delivery in London, but for the rest of Ontario, it's next-day delivery. Use like FedEx and Canada Post, so your home, work, or cottage. Really exciting. We also have a health store of over 5,000 health essentials and over-the-counter products. We're free shipping with your prescriptions, or if you get it with your sent with your prescription, or if you spend over $50. A lot of times you get everything in automatic refills for patients. You can use technology. We have like website and all that kind of stuff where you can see your meds, but often a lot of our patients, if they're older, they like us just to call them. We sync everyone's meds all together. If you have 10, 12 meds, whatever, we sync them all together. So you get them at the same time. We call you 10 days in advance to see if you need anything else. And often we'll have patients say, yeah, get me some vitamin D and a pack of Fisherman's Friends, and we'll add that to your order, and free delivery. We offer everything that a pharmacy does and so much more. We can dispense any type of medication in vials, nasal sprays, compounds, so creams and ointments, liquids, specialty drugs, but also we can put medications for you in pre-sorted and convenient daily dose packs that arrange them by date and time for you. Easy tearaway packs you can take with you wherever you go. Even my father uses these now, I told you, 72-year-old physician, because he's working full time still, and he's got a couple chronic conditions that he wasn't taking his daytime dose because he's working so busy. We had to razz him a little bit and say, you're that doctor that says, do as I say and not as I do, until he decided to get his meds filled in these daily dose packs. Now, at no extra charge, by the way. And when he just takes them in his breast pocket of his jacket, of his blazer, and he goes to work with them every day. So easy to take with you wherever you go. And then also we have preferred partnerships. Being a not-for-profit, yes, we're donating a lot of our clinical pharmacist time. By the way, we do free clinical consults for everybody, even if you're not a patient of our pharmacy, at least to identify some problems. That's part of our donation. We do give a lot more clinical care that we don't get paid for that, but that's how we're giving back. But also, being not-for-profit, we want to make things a little more affordable for people. So instead of paying a $6.11 copay if you Ontario Drug Benefit Program, some pharmacies waive it down to $4.11. We waive it down to $2.99. Or if you're $2 copay, it's zero for us. So zero and free delivery and free single dose packs, free everything. What happens if your meds are not covered, if you don't have a plan or you have a private plan? Well, we have a very low preferred dispensing fee of $7.99 with our partnership. So call us to learn more. It's comparatively, it's very, very low compared to a lot of other pharmacies. But, this is the main, it's our passion for improving clinical care and make sure it's the right dose for you is why we form partnerships, and especially with dementia with Alzheimer's Society of Ontario, now with all the 30 locations. We specialize in supporting the health and wellness of older adults who have chronic conditions, especially those with conditions such as dementia. Our clinical pharmacists help to resolve any issues and help personalize medication based and help you live your healthiest life. We offer free clinical consultations by phone or video from the privacy and comfort of your own home. So we have a safety checklist. We can help distribute this as well. But it helps then with all the care coordinators with Alzheimer's Society. They have access to these, and with flyers, we have flyers we can hand out as well. That is a checklist. And if you have any one of these checklists, one or more, you could definitely benefit from a free clinical consult. Whether you're dizzy, tired, sleeping during the day, forgetting things or struggling to keep new information, unexplained weight loss or gain, constipation or nauseous, headaches throughout the day, not getting what you expect out of your medications or taking 5 or more prescriptions regularly, then you can get a free clinical consultation at the Health Depot. Absolutely. Here's an example of the flyers we're handing out through our partnering organizations. And in order to book that, you can call us. Here's our local numbers, 226-330-0200. We have a toll-free number, 1-800 number, 1-855-844-2242. Or you can visit our website. Our website is www.thehealthdepot.ca. But we do have a preferred landing page for our dementia program. It's just /dementia. You can go there, click book a consult today, and then just look in the calendar and say dementia care consultation, and it could give you times if you want to do that yourself, or just call our team, and every team can help schedule an appointment for you. So yeah, I would love to see if we have any questions. Sorry, that's I'll try to breathe here for a moment, but
yes, breathe. Oh my goodness, Andy.
And see if we have any questions from anyone. I'd be happy to share. I know we have that went a little longer because we started a little bit late, but I'm happy to stay past 8 o'clock if people have questions.
No worries. I'll give people a minute to put some questions in the Q&A, but one thing we always get asked about, or I guess that might be helpful for people to know, is it's often hard to tell when someone with dementia is experiencing pain, right? Because they can't always tell you, I'm in pain. Do you have any thoughts on that, Andy?
Yeah, it's you're right. If it depends on how they can communicate. If they're struggling with the communication, oftentimes they'll show up as being you have to kind of look at it more irritable, right? And like more furrowing of their head. Like there's some signs and stuff like that but that sometimes that can be also with a UTI, right? But if they're in pain, they're definitely more irritable, and it depends on what they're pain with. There might be trying to protect a certain part of their body, or they're struggling. You can see that they're not trying to walk often, or they're struggling too with their gait in their walking. It doesn't look comfortable. There's things like that you can notice. But you're right, it's difficult. It's if you're around them and you're a caregiver and you notice things getting worse, that's when it should definitely be tipping you off that you might need to look into that.
So it's looking at those nonverbal cues rather than,
Yes.
yeah, because if you ask them, they might say, no, I'm perfectly fine. But meanwhile, you know,
Yes.
they really are experiencing pain and
And
you can tell non-verbally.
yeah, and a lot of times, and this is like true of anything, like what people say in a conversation is only 7%, believe it or not, of the conversation. 35% to 37% is nonverbal, like your tone, like your tone, but then 55% is your like your visuals, right? So if they're like, you know, as they're getting up and like, I'm fine, you know, like they're gritting their teeth and you can see that furrowing in their face, that's like a good sign that people can't have a tough time of hiding. So like they may try to, and there's also God bless, like even my grandparents, they would never complain about anything. And so that everything was always fine, right? It's like, well, you could tell that when they're struggling, right? But they would never admit they were in pain. It was brutal. Like they were just that they is like my grandfather in particular, he was always like, I don't know, he did never wanted to have his problems ever expressed to anyone else. So you just had to notice those nonverbals to try to get him some help. Yeah.
So our first question, and it kind of relates to what you just discussed, but specifically the question is, can a person with dementia misrepresent their pain as stiffness?
Potentially, and that's like, you're right, that is like tricky. Stiffness is, yeah, that's a tricky one because stiffness does cause pain too, right? It's like a different kind of pain that sometimes they need to go stretch and you know, you need to get a lot of people with arthritis, they have that stiffness first thing in the morning, especially osteoarthritis, which is important to get up and get moving. And, you know, warming up the joints helps a little bit, right? Like in warming. But yeah, it's a lot of times trying to push through. And the problem is, like, as I mentioned, people often have to try to live with comfortable levels of pain that doesn't affect your daily life and whatnot, or it can get worse. So it's important to try to encourage to constantly try to get up and walk and move, go like even doing pool work, like, so it's less, you know, but it's important to try to get as much activity as you can safely, right? Without, you know, yeah, absolutely. It's tough. Stiffness is because then it's something that some people can slowly improve on and can get a little bit better, whereas pain, it's just a second. I'm gonna have to go stop that alarm here. Just 2 seconds. Sorry.
Okay. That's great. Thanks. And,
Yeah.
the next question is, this is a good question. How can we determine if dementia or a drug interaction is the culprit?
Yeah, you're right.
No.
So the issues that drugs have, and this is like, it's more like I'm giving a presentation tomorrow at 11 a.m. on medication that caused dementia, believe it or not. And I did one yesterday with Alzheimer's Society of Ontario. There are medications that even if you take, for an example, like off those beers list, anticholinergic drugs, what they do is they block our ability for muscles to contract, acetylcholine in our body. Get a little nerdy here. That's what our bodies use to, you know, contract your arm, your legs, but your brain's a big muscle. And if you have these drugs, they act in your brain and they can block your ability for your brain to contract in certain ways, which can limit our ability to even have dream sleep. Dream sleep has a purpose that it helps. That's the kind of sleep that REM sleep, rapid eye movement sleep, helps our brain consolidate new memories and learning. And over time, if you take one of those drugs, they found there's studies, multiple studies that have been done. They find that if you even take one of those anticholinergic drugs, and there's a huge list of them, for 3 years, it can increase your risk of dementia 50%. And, you know, your risk of Alzheimer's disease, 63%. It's a cumulative thing. And the more of those drugs you have, they're anticholinergic, the more rapidly you can get dementia, or it can progress your symptoms quicker. So yeah, it's tough you know, it's one of those things that when you get, if you have dementia and you're over a certain age, which just get you off any anticholinergic drug and onto safer alternatives. Like, as I mentioned to you, that beers list that I did at the tail end of the presentation, they're atrocious medications that 31.1% of seniors take at least one of them, that we should be getting you on a safer alternative. And yeah, it's certain medications cause dizziness and drowsiness and all that. And the more you have of those medications, the more that those side effects compound each other. And certain meds will slow down your liver, so then these other meds will stick around longer, like I mentioned with cannabis. Like, there's a lot of those things. So you need to look at you and the whole, like, it's like all your conditions of you as a person, understanding that why you're on certain, to try to make sure we can treat all your conditions, but make sure all the meds cooperate kind of together to not overwhelm and cause these bad issues to you. Because a lot of times there's a and this is the problem of our healthcare system that we've had for a long time. Lots of doctors and surgeons and whatnot in my family, is that, you know, we're quick to reach for a pill and just tout the good of a medication, but not actually some of the cons and the negatives of those meds. Everything you put in your body can have a positive effect and a negative effect. And we need to triage them to know whether or not it's the right one. For what works for you, for Tara, for Catherine, doesn't necessarily work for me, right? We have different food sensitivities and different food allergies. We need to personalize those medications. And if it makes you really, really dizzy, well, there's another alternative we can try to treat the same condition that doesn't. We shouldn't be suffering in silence from these bad side effects, because over time they compound. And often you see doctors treating, oh, here's a medication for your dizziness. Well, now that medication here is causing swollen ankles. Well, here's a fluid pill to treat your swollen ankles. Now, with those pills, you have urinary incontinence. Here's a medication for your urinary incontinence. Now you're having, you know, like, it's just, it becomes a snowball effect, when all we really need to do in the first place was to get you off that medication that was causing your ankle swelling. So it's like, we need to look at it that way and really trying to help personalize medications.
Thank you. Question, how do you know when to use cold versus hot pads for pain?
So pads versus gels and things like that, they're two different things. So
yeah, so no, cold versus hot, like a cold
temperature.
compress. Yeah, cold compress.
Yeah, okay, not the sensation. I hate that. Like,
No.
you remember Shaquille O'Neal, the icy cold patches? Because it says they start cold and then they become hot. And everyone's like, that doesn't make sense. It's because it's just to numb pain, right? But cold is primarily now only used if you've like twisted your ankle and it's ballooned up, to try to reduce the swelling temporarily, and just tepid cold, not ice cold. It's now more so warmth. Yeah, because as I said, healing, warmth causes blood flow increase to the area, which helps promote healing. Whereas cold gets those blood flow and the blood vessels and whatnot to shrink away. So then you're not bringing new nutrients to help recover injuries. So that's the kind of thought. But you're right. Like, if you twist your ankle and it ballooned up a lot, like, you want to get some of that swelling down, but then you have to immobilize it. Pain has a point, especially for acute injuries. It's meant to stop you from using it. When you twist your ankle and it balloons up like that, it's telling you, do not step on it. You need to stop. You need to repair. You've done some damage.
Yeah.
So if you continue to walk on it, we didn't have that pain, then it would make it worse. Interesting fact. A lot of people don't know this. Leprosy is a condition that doesn't disfigure you at all. People don't know that. They think it like makes you hideous and, like, you know, the old movies and whatnot. Leprosy causes you to not feel pain. It blocks out all your nerves. So when that happens is, you know, for instance, if you're turning a key in the lock, you know, if you turn it too hard, your hand hurts. You're like, ow, you stop. But someone with leprosy won't stop. They'll just keep going until the key actually digs and cuts open their hand, right? So it's very important signal to get us to stop, to not cause further damage. So, but the problem is when it becomes chronic, you know, at that point, it's not an injury, it's just causing more problems and stopping us from, that's when we need so warmth is, especially at chronic injuries, warmth is what you do. It's not cold, because cold is only for short-term inflammation, you know, an acute injury.
Yeah. So just a follow-up question that just popped into my head. So for an older adult, perhaps if they're quite slender or frail, would you say kind of moderate warmth versus a heating pad that could get too hot?
Yeah, it's like I mean, it's everyone's got their own comfort level, but yeah, you're right. Like warm is better. And that actually, if you have sore joints and whatnot, warmth can help to get that blood flow to the area and improving, but obviously not if it's a swollen joint, right? So if you have, rheumatoid arthritis or, gout or something, don't. Heat's not a good thing to do.
Right.
That's where, medications you definitely have to take for like gout, but yeah, it depends on what the pain is coming from, for sure.
Great.
Yeah.
Thanks, Andy. Just a
No
few more questions. Are lidocaine topicals like Asper cream available in Canada?
There are some forms behind the counter, like xylocaine is a very common one. Some formulations of lidocaine are available behind the counter in your pharmacy sometimes. There's special order ones, but most common xylocaine. But yeah, it's a topical anesthetic. You just have to be careful how much you use that stuff, because again, it's like you don't want to numb. Like if it's chronic pain, yeah, it can help, right? But if it's an acute pain injury, you don't want it becoming chronic, because the idea is if you ignore pain when it's acute, then you keep blasting through the pain and trying to ignore it. That's how it can become more chronic long term.
Right. Next question, is TENS effective for sciatica?
TENS, it depends. Like not much touches nerve pain, so it's not as good for nerve pain. It might still help if it's a localized nerve pain, to like numb if it's a throbbing pain. Usually it's not very effective for nerve pain though. No.
Okay. And next question, are CBD capsules as effective as oil?
A lot of CBD capsules are oil, so like oil in the capsule. It depends on which type of CBD like you're referring to. But yeah, oral is much better. Like definitely avoid inhaled, because that creates a lot of problems. But yeah, CBD oils and capsule oils are very similar. And there's a lot of sublingual, believe it or not, as well, that you can put underneath your tongue and absorbs directly into your blood. Those are becoming a lot more prominent as well. But like I said before, just make sure you're doing that with the consult of your pharmacist, your clinical pharmacist, as well as your doctor. That's something that we're trying to really help out a lot more with, and we're starting to form some partnerships to try to help out with that. It's game changing for people. It helps the trifecta, especially in older adults. We're the preferred pharmacy for CARP for all of Canada as well. And there's a big need in older adults because it can help with pain, sleep, and mood, right? Which is, they're all kind of related, as I mentioned, that downward spiral that can happen. So, but the trick is you need to have, I can't stress enough, you need to have your other medications adjusted if you're going to go on it.
Okay. And one last question at this point. How would it work politically if Health Depot advises against using drugs that a neurologist has prescribed?
We work together with your doctors, so don't worry. So like I said, this is informational purposes only. But then if you're a patient of the Health Depot, we work together with all your doctors. So with your family physician, often your family physician won't touch a drug that one of your specialists has done. Then we reach out to your specialist to find out, right? And because there's specific reasons, as I mentioned, certain drugs, there's 30 different reasons why you could take a certain medication often, right? We have to talk to the doctor to see if there's even a suitable alternative for the same condition that could be used, depending on how you're feeling. And there's sometimes, like I told you, that Beers List medication, sometimes there's very, very specific reasons why you have to be on one of those medications that, other alternatives won't be suitable. So that you have to weigh out the pros and the cons of everything. So sometimes the pros outweigh the cons. So even you might have to suffer with a little bit of dizziness and lightheadedness because it's solving this issue. And you have to look at it on a per person basis. But we work together with your doctors to get a very collaborative, like it's like that kind of hospital level collaboration care in the community is what we call it. So like if you go into a hospital, you often see doctors working together with pharmacists with blood work and feedback from the nurse to make sure we get you on the right medications for you. You see patients sometimes going in the hospital on 17 medications if they fall and broke their hip, for instance, and they come out on 5, like 12 unnecessary meds that are deprescribed. I've heard of tons of different situations like that have accumulated over the years. Well, we want to help to try to work with the doctors in the community, specialists, and your family physician to make sure you don't get to that point that you even have to go to the hospital in the first place. So, yeah.
Sounds good.
So we have to do it. And just so you know, the future, I think, is pharmacists being more involved with actually helping to pick the medications. But for now, we also have to work with your doctor. So still the doctor's picking the medications, but we help to suggest. And what we're doing is often, like, I get asked, like, do doctors like it? They love it. There's one of the local doctors who teaches at Western, even adamantly said, about effing time pharmacists did this, because they know that's not their expertise. They know that that's our expertise. And they love the idea that we're helping out with that and collaborating with them. And when we send a communication to the doctor, we'll make recommendations saying, hey, well, Dr. So-and-so, you needed to change the patient's dose from 100 milligrams down to 50, then down to 25 milligrams of this drug because the patient's kidney function is this. Give them a number, proof, and this is high and toxic for them at this level. And the doctor's like, oh my God, thank you. Yes. You know, so because we're helping to find those points. There's certain medications and thresholds when you need to lower your dose for safety. And sometimes we need to even take you off that medication, put you on another one at certain levels of your kidney function. A good example of this is metformin. I often say that if you're type 2 diabetic, you have to be on metformin. It's what your body, that tells your body how to listen to insulin, whether or not it's your insulin or injected insulin, right? It's how our body can use insulin. Well, if you're below, if you get down to 50 in your creatinine clearance, which the average 70-year-old female is around 50, you can no longer take 2 tablets twice a day. You have to take 1 tablet twice a day. And then when you get below 30 for your kidney function, you have to go off of it because it can be very toxic for your liver. And those thresholds often are being missed because a lot of doctors don't know those thresholds and aren't aware of them. And that's where, you know, as a pharmacy, as a profession, we need to help step up because that causes more problems down the line. We shouldn't have to fall, break your hip, or have a stroke or whatever to go to the hospital for us to deal with these. We need to help prevent you from going there in the first place. So that's kind of the goal, is we need to help serve that. That's our expertise. And we need to help teach that in pharmacy schools. Like the blood work assessment is not something normal they teach in pharmacy school. I learned that as a CGP, but that's something I'm trying to get in the curriculum, and that we're teaching all of our pharmacists at the Health Depot. And we see as a huge, the future, we need that. It's we just can't put you on a drug because the drug rep said it was good. We need to make sure that, you know, often my dad will admit, for certain conditions, he gets everyone who's on high blood pressure, he puts them on this drug. Everyone who's on, like, the doctors get comfortable with one drug, but there's hundreds of different drugs for each condition. And what works for you doesn't work for me. We have a lot of food insensitivities. Like even my own family, I have my mom's allergic to shellfish. My dad can't have dairy. My sister can't have everything. She's can't have gluten. She can't have spices. Poor girl. But that's just food that we naturally eat. With medications, similar. We have bad adverse effects or allergies. We need to be able to have those personalized for each of us. And they have to go down as we age. As our kidney functions go down, our liver functions go down, our doses for the medications also have to come down. Our bodies are continually changing. Our medications and our doses also have to be continually changing too.
Yeah.
So
thank you so much, Andy.
yeah, thank you.
Always very informative when you present for us. And I just love your enthusiasm and your passion. It comes through loud and clear when you present for us. So thank you everybody for coming. Yeah, thanks again, Andy. And we'll have you back for a different topic next time.
Sounds great. Thanks, Tara.
Great.
Thanks, Catherine.
Thanks everyone. Have a good night.
You too.